Good evening. I'm Dr. Jeffrey Spear, current president of the El Paso County Medical Society for 2022. We at the El Paso County Medical Society are very proud of this program. We are certainly grateful for the collaboration of both Star City Studios and KCOS for making this program a reality. We are also incredibly grateful to Ms. Catherine Berg, who has been such a terrific partner for the last 25 years being this program's host. We hope you continue to join us each and every month for this fantastic program, and please enjoy the presentation tonight. Thank you very much.
I remember sitting here on St. Patrick's Day, March of 2020, and at that time, and I'm looking at both of the doctors with me, at that time, everyone in our office was told, go home and don't come back until we say so, and we thought it was going to be a couple of weeks. It was this new thing called COVID-19, and we didn't know what was going on. We just knew that we were going to be working from home. But here's the thing. I'm healthy. I didn't have any treatments I needed to take care of. I didn't have any screenings I needed to take care of immediately. So I was lucky. So were a lot of other people. But we're here this evening because we're talking about others that did not have a choice but to go in and get treatments, or some people elected not to come in and get treatments or screenings because of this new thing called COVID-19. With us this hour, we've got Dr. Inez Sanchez and then also Franz Barthard. And we're going to be talking specifically about that. I appreciate you watching. I'm Catherine Berg, and this is the El Paso Physician. Thank you again for joining us. Tonight's topic is COVID's impact on cancer screening. And with me tonight, we have Dr. Inez Sanchez, and she is an oncologist and hematologist, and she's also the medical director of Texas Oncology in El Paso, and also the research director. So we're going to talk about how COVID-19 has affected research as well. And then we also have Franz Berthard, and I'm saying it wrong. Did I say it right this time? Berthard, who is the director of oncology at the Hospitals of Providence. And so Dr. Sanchez says, you're the guy that makes the magic happen. So we're going to have magic happen here this evening. As you may have noticed, we are in a different place. We're in a new studio. We have Diego and Daniel here with us who are helping us out. And this is all exciting for us. And if you have any comments, let us know. That's always helpful. But the first question I want to do is ask Dr. Sanchez for you to explain what you do, and then I'm going to have you do the exact same thing so our audience kind of knows what's going on, if that helps. Dr. Sanchez?
So I see patients with cancer pretty much all day.
Mm-hmm.
I mostly breast cancer. That's my main specialty. And I also, I pretty much see them develop a treatment plan, and I execute the treatment plan, and I monitor for toxicities. And then, part of my job is also look into clinical trials and the possibility of how a patient will match with a particular clinical trial, if they will benefit from participating or not. And then pretty much that's what I do every day.
Mm-hmm. And that's a lot because you're looking at everything. And I'm glad that you brought up clinical trials. Franz and I talked about that a little bit earlier, and there's so much research that hasn't been done for various reasons during COVID. But if you can kind of stop to and explain what you do. You've been here a couple of years now, and you're from New York. You said you were recently in Boston.
Correct.
And now you're in El Paso. Thank you for coming. I hope you like the Mexican food here because it's pretty dang awesome.
Delicious.
But explain to people at home what you do.
Absolutely. So I've only been here a couple of months. So I feel I'm still fresh in the community, but everyone's so welcoming. So I'm really the administrator across our entire market. So when we think about the Hospitals of Providence and oncology, how we provide cancer care across all of the various hospitals. In a big part of my role, I see it as getting rid of the obstacles. So amazing physicians like Dr. Sanchez here can do exactly what they do, work miracles. So getting rid of obstacles, getting them what they need, really creating an environment where the physicians and nurses and all of the clinical team can do their job.
On that note, Dr. Sanchez, this is a perfect pivot to you because we talked, luckily we had some time before we were on air to just discuss things that have been going on. And during COVID-19, it's impacted healthcare in so many different ways. And you being an oncologist, what was the most poignant thing that you noticed over the last couple of years of how it's impacted oncology specifically?
So at the beginning of the pandemic, we did not know how this was going to affect anybody, but we became very quickly aware that that our patients had a target on their back with this virus.
Right.
So it was very clear to me that the most immunocompromised, the most sick patients were the ones who were going to pretty much do poorly with this virus and even die. So, we actually lost in the community, we lost about 250 cancer patients to COVID-19 in the first year.
In the first year?
In the first year.
Okay.
That was 2020.
Okay.
And that was actually pretty heartbreaking to us. And then we started to think, how do we protect our patients? How do we make sure that they don't get sick, that they don't die, and pretty much what we started to do, that is also heartbreaking to me, is we started isolating them.
Yeah.
We wouldn't let family go visit them. We didn't let, pretty much they were being seen through the window. They were, grandma, mom, brother, sister were pretty much, that was the tragedy of all of it. I had to isolate my patients to keep them alive.
Right.
And also to allow them to have access to care. We had to convert a lot of patients, a lot of visits to telemedicine to be able to then allow access for the chemotherapy patients, for the patients who were immunosuppressed, for the patients who actually needed to come into the centers.
And you were talking about earlier, and this is such a point, with COVID and just the CT scans and things that we needed screening, yes, but also finding out what stages people were in. The CT scans were completely overwhelmed by COVID patients.
Yeah.
And that's another impact too. If you can talk a little bit about that. And then actually I've got a very specific question for you too after that.
So what happened with, we were lucky enough that we had our dedicated CT scan, but we had to screen everybody that would have access to that CT scan. So we made sure that everybody that went through that CT scan was healthy. But, we were only one center that we had the scan. But if we needed the other imaging places, especially the hospitals, were totally overwhelmed. Right. So they were actually, like those CT scans and those imaging places were actually closed for the rest of the patients. And during the lockdown, pretty much only essential things were being done.
Exactly.
So that was also another barrier to care, to access. And on top of that, people were terrified because they thought that if they put a foot on the hospital, they were actually going to end up having COVID and dying.
Right.
So it was a lot of fear of the unknown. None of us knew what was coming. I mean, I had to go every week. I went through a webinar to just know more about COVID-19 and the impact on the patients with cancer, so I could actually help my patients.
Right, exactly.
But it was crazy when we figure out, okay, the cancer patients are target number one for this virus.
Target number one, and that's something too. When you talked earlier about 250 cancer patients dying of COVID, yes, there are underlying conditions, but again, at the end, that's what it was about. Franz, we talked a little bit earlier, and how has telemedicine helped us, number one, and how do you see the world of medicine and seeing doctors? And just what we were talking about earlier, pharmacies are going to be able to do some prescriptions now, et cetera, et cetera. And that conversation we had earlier, I'm just glued to everything you had to say.
Yeah. So really, I think what happened with the COVID pandemic is it illuminated for us aware that we have so many inefficiencies in our healthcare system, and we tried to kind of squeeze all of this work into a smaller window of time because it was life or death. So when you think about the COVID vaccine, from kind of creation to implementation and dissemination, it was a much smaller window than any other public health effort like that. Paxlovid, with regard to the oral medicine, kind of that type of innovation, the telemedicine. I was in Boston at the time at the Dana-Farber Cancer Institute, and we scaled up our telemedicine infrastructure in 7 days because it required that type of ingenuity and persistence to be able to do that. And I think you can't scale back access to care. Right. Now that we have it, and especially for populations, when I think about the demographics that we serve here in El Paso, who often go underserved and have limited access to healthcare and cancer care, certainly, we can't take away what we've kind of, we've showed our hand with regard to the healthcare system. And I think it requires us to keep that same thought process, that same focus on inequities, disparities that the COVID-19 pandemic illuminated for a lot of folks, and really push forward with that.
There have been, instead of going in for colon cancer, to me that's the easiest one to refer to it, this, because you've got Cologuard that you can do at home. You got the colonoscopy that you do in clinic. What are some of the screenings that have been occurring that were in the clinical setting before, but kind of shifted a bit during COVID? And what are your thoughts about that in general?
So the main one that comes to mind is Cologuard, because that one can be done at home. And then the main problem with Cologuard, and I'm no expert, in this, but is that if you come back to be positive or actually abnormal, then you still need a colonoscopy.
Right.
So, one of the things that we were talking about before is how many people did not get their screening tests during the initial year of the pandemic, and I have some amount that is like 9.4 million screening tests that normally would occur, did not happen in 2020. So, and what does that then translate is that pretty much the 80 to 90% decline in screening for breast, colorectal, and cervical cancers that are our number one screening, our number one winners, actually, because the screening for breast cancer and cervical cancer has been had made such a big impact in mortality. Like pretty much we went from breast cancer being the number one cause of death, is now the number one the most common cancer in women, but actually it wasn't the number one cause of death because of how good our screening. Yes. So, but we actually lost about 80 to 90%. There was an 80 to 90% decline in screening for breast, colorectal, and cervical cancer during March and April. That was when the lockdown happened of 2020 compared to the year before.
That's amazing.
And what that translates is into about, a 1% increase in death.
Yes. And 1% is a big number when you're looking at that.
It's a big number across the United States.
I would love to, we're talking about this in the last couple of years. And Franz, you were talking earlier about we have not even come close to seeing the magnitude of this yet. And 10 years from now, 20 years from now, the catch-up of missing screenings over the last, you're talking about 2020, and some now over 2021. Talk a little bit about that. What do we have to look forward to futuristically on what we did miss over the last year and a half?
Right, and I think there's 2 points I want to make, because and I think you alluded to it, we're still in the pandemic, and we're almost seeing this synchronous in El Paso mountains and valleys of when there are surges and subsequent surges when we expect there to be kind of lower screening rates. And as Dr. Sanchez stated, that 1%, approximating to 10,000 people, and that estimation is over the next decade. And so the NCI is already presuming we will lose, 10,000 people in excess cancer deaths because of a short period of time when folks were not screening, right? And we assume, and Dr. Sanchez and I were talking about this earlier, there are still people, we're 2+ years into this, who have not got their regular screening. And so we're making estimations, but we're not going to see that full manifestation of later stage or advanced cancers when they finally do come in or get screened.
Exactly.
And I think that's probably where we have a lot of that apprehension. I think more folks are starting to come back to screening, but that volume hasn't gone back to what it was prior to the COVID-19 pandemic.
Right. And Dr. Sanchez, you were mentioning earlier a woman that is high risk, and she was supposed to come in to get a mammogram, and you just simply cannot get her to come in.
Yeah.
Without saying names, give us a story, a case study of some of these patients that you see that totally do need to come in, but aren't because they're scared. And let's talk a little bit about what has been put in place by the hospital systems. That yes, it's the time of COVID, but your cancer is still number one that we're looking at, and be careful without question. We've had all kinds of conversations today about being careful, about at the same time not ignoring what's actually happening, not ignoring the cancer, not ignoring the screening. If you're high risk for something, go get screened. This would be a great time for you to give all that information to the audience.
So, there's actually multiple patient stories that I have that, especially 2020, I explained to them, I went and had my mammogram, I would be the example. I said, I went and had my mammogram, and I can guarantee you that everybody's taking every precaution, that everybody's wearing masks. We still healthcare providers, we're still required to wear masks at our places of work. Everybody has to wear a mask.
And you were wearing yours just to give.
I was wearing mine just in case my patients are watching.
Absolutely.
Okay,
Yeah,
and we are spaced.
Mask up.
Yeah, mask up, and we are spaced out.
But my God, but pretty much it's like I just saw a patient recently, and I look at her screening, and I'm like, okay, what happened with the mammogram? You did not have it in 2020 because it was the lockdown, but I ordered it, and you were supposed to have it, and then I see her once a year. Comes 2021, again, she did not have it. So this time I said, you know what? You're having the mammogram, and I'm doing a very short follow-up with you because I need you to have it. This is so important. You already had breast cancer. If we catch it early, then you don't have to go through all those treatments that you had to have before. So, but the fear was very real, very real.
I would love either one of you. So the idea of early detection. So here early, colon, I feel like it's one of the cancers that if you catch it early, if you get your colonoscopy, you get those polyps removed, there goes the chance of that cancer. It's so very much important. So early detection, what are some of the cancers specifically that early detection is where it's at? You were at a lung institute before this, and that's one of the harder ones.
Right.
Because there's not technically a screening for that.
Right.
Well, there is a screening for lung cancer, actually. There's established screening protocols for lung cancer. There's actually low-dose CTs that are established to be for high-risk patients. And that's one of the things that was actually affected mostly by the pandemic. Because,
that's right, because of COVID and the CDC.
Yeah, because if you find those tumors actually at a place where they can actually have surgery, they might or might not even need any additional treatment. But there's actually El Paso also has a cancer screening program, but it's usually by the pulmonary groups, and of course they were embedded into COVID.
Right.
That's something that is one of the tragedies of the pandemic, if I can see one, because lung cancer is the number one killer of women and men in the United States.
So you almost imagine the people who would be doing those screenings were needed the most in the COVID-19 pandemic.
Right.
Right. And I think that's where that tragedy you spoke of, that's really where we saw it.
because breast cancer is established. We know that breast cancer, when it's found early, you minimize the risk of losing your breast, the risk of needing chemotherapy, and sometimes even radiation, because there has been some new data that radiation can be avoided on some particular patients. But that is probably number one in my list. Cervical cancer, if it's detected,
exactly.
subclinical, it can actually be cured before needing anything. Colorectal cancer, if it's found early as a screening rather than as symptoms arise,
Exactly.
then you can have surgery and not even need treatment. Just need follow-up. So I think we lost quite a bit on those four fronts.
Right, agreed. I'm curious as to something that you both had talked about with lung cancer screening. So what is the word I'm looking for? What is the platform you need to be on in order to qualify to have a lung cancer screening? I'm not a smoker, I don't have a cough, I don't have any, doesn't make sense for me to go have a lung screening, nor would the insurance cover it, I think. When is that a screening that is either covered by insurance, or when people know, okay, you know what, I need to go have a lung screening, or is it called a lung cancer screening?
Right.
It's new to me. Sorry, can you tell?
No, you're good.
But I'm
good.
excited about it. The audience already knows this, but my mother, it's been 29 years, but 29 years ago, my mother died of small cell lung cancer.
Wow.
So it's always fascinated me, like, how did she not know? I mean, it was the size of an orange by the time we found out. In general, now that there's a screening, who is qualified to get that?
Right, and I'm going to look to Dr. Sanchez to back me up here, but there are, what consists of that high-risk category. Certainly folks who are multi-pack day smokers in the past, though I say that knowing that there's almost a stigma with the non-smokers, because folks who've never smoked can also develop lung cancer. Similarly, age as a risk factor for lung cancer as well.
And any chronic lung disease, like asthma, emphysema, chronic bronchitis, not necessarily associated with smoking. And I'll stop right now because I don't want my pulmonary colleagues to come after me. But that's kind of pretty much like the basics for lung cancer screening.
And this is something that I usually do, and I'm going to say this now for everyone in the audience. We do the best that we can with the questions that we have, because sometimes I'm just shooting a question out at you, and we do actually have a disclaimer that says, don't hold you guys accountable, because sometimes you just don't know. We have two doctors on, and we're talking about oncology, and how many different cancers are there? A ton.
I know.
This is also why we have that going on. So as that disclaimer, I would love to talk a little bit about breast cancer for a moment.
The main thing with mammograms is mammograms are very good, especially to detect what we call the earliest form of breast cancer. So that's what we want. We want to detect the little calcifications that still have not gone through the ducts, or become what we call invasive breast cancer. And because the invasive breast cancer is the one that actually can go some other places. It can actually go into your lymph nodes. It can actually go into the rest of the body. And those are the ones that actually we have to do more aggressive treatment depending on the kind of breast cancer that we're looking at. So, like ductal carcinoma in situ is what we call a stage 0. And then we have, stage 1, and stage 1 has multiple subdivisions, and then stage 2, stage 3, and stage 4. Stage 4 is when it has already metastasized to the outside of the body. Stage 3 is usually what we call locally advanced, meaning that is a big tumor, and sometimes it's associated with a lot of lymph nodes under your arms.
Okay.
And then stage 1 is usually localized. It has not usually spread under the lymph nodes. And then depending on the receptors like estrogen and progesterone and HER2
Exactly, right.
It depends. So that's kind of what the prognostic factors goes into. And then we have a test that we do, Oncotype DX, that is now part of the staging. And then, when you go into like stage 2, it still could be somebody who has very little lymph nodes, or it could have lymph nodes that are negative, but it's a bigger tumor. So it's like all across. But the mammogram in itself is actually, if you do your screening mammogram, you're more likely to detect it at the stage 0 level. But there's
a stage 0 level. I didn't even realize
yes,
that.
that's
Okay.
the ductal carcinoma in situ. That's the one that
Okay.
has not penetrated through the ducts. So that is just calcification. Sometimes it can form a tumor. But it's actually, that's the earliest form of breast cancer, and it's usually cured by surgery. And then when you are doing mammograms, depending, if you palpate something and the mammogram is negative, that still needs to be investigated.
Right.
Because there's no really, the mammogram could be wrong, or it could be like a mammogram silent tumor. But if there's a palpable mass, it needs to be addressed.
Right.
And then you have different types of mammograms too. So you have the mammogram that is your regular mammogram, and then you have tomosynthesis, that is actually, or what we normally call 3D mammogram.
Oh, yes. Okay.
And it is available at the hospitals of Providence. And they squeeze you harder.
That's the one I get, though.
Okay.
I'd rather be squeezing very hard and know what's going on.
That's the one.
This is that show that we're allowed to say that. I know it's kind
That's
of weird.
the one I get too. But
Yeah.
is actually, they squeeze you because what they want to do is, if you have dense breasts,
Right.
that is the best one for dense breasts. It's like flatten up that tissue, and it allows you to see better.
Right.
And sometimes we have to supplement that with a ultrasound.
Bingo.
If somebody doesn't qualify for a tomosynthesis or 3D mammogram, then an ultrasound would probably be appropriate, because if you have dense breasts, then you cannot really trust the mammogram.
Right.
that
And
well.
explain why. And I like that you said that, because, and again, think about it, and I wish we had an x-ray right here
That
or a
would be-
mammogram.
yeah, that would be good.
But if you're looking at dense breasts, there's a lot of white spots that are
Exactly.
normal portions of the breast, milk ducts, et cetera. And to find a mass in there is sometimes a little bit difficult.
So
if you
because
can-
the mass also looks white.
Right.
And then sometimes it's easy to like spot it because it looks like a star and it's spiculated, what we call. But then sometimes it's round, and it pretty much like it is camouflages with the tissue, and then you can't see it.
Right,
So
yes.
that's the reason that is so important
Right.
to do that.
And that makes perfect sense too, because I think sometimes people are not understanding of the sonogram versus the mammogram. You brought something else up, and Franz, I'm going to get back to you, but this is
good.
breast cancer, and this is always interesting. So HER2 it's a protein, right? And there's and the BRCA gene, and I don't want to get too much into DNA and studies, but we hear a lot about the BRCA gene.
Yes.
And the way I understand is the BRCA is for breast cancer BRCA gene. And there's mutations. We all have them, and they could be good, they could be bad. It's about the mutations. And this is not about mammograms and or ultrasounds. Now it's like, okay, what type of cancer does one have? And when you said, there's some that are hormone negative. If we can go through some of those, once someone has diagnosed, there's a mammogram that comes back. There's definitely something on the mammogram we need to check out. What are the tests then, or how do you diagnose what type of breast cancer a person has?
So the patient undergoes a biopsy.
Okay.
And then one of the things that the pathologists do is that they run these tests. So the tests are estrogen receptors, progesterone receptors, and HER2 new
Okay.
amplification. So, and sometimes they do it's like a stain, and it's like 1, 2, 3. And then 3 is definitely positive, and 1 and 2 are what we call low positive, and 0 is negative.
Okay.
So HER2 new is actually something that we have targeted therapy for. We have something that is called Yeah, I saw you.
I did target therapy. That's a whole nother one. Man,
So
we've got
we
so
have,
much, yes.
Medications such as Herceptin, and we have actually Perjeta that they target the particular HER2 protein, right? When it's truly positive. Now, recently we have some data that we have a medication that is actually targets and is effective against the low HER2.
Got you.
So,
right.
and that's we're waiting for FDA approval, but I think it will be approved because the data is amazing. So, but it is I can't. It's trastuzumab deruxtecan. That's kind of what it is.
Oh, that's easy for you to say.
I know, right?
Oh, goodness.
But anyways, is an amazing development that it just got presented in the last month or so. So we have a new tool.
And it's so fascinating because, again, this is the 25th year of doing the El Paso Physician. And I remember you being on, we were buddies in the get-go, probably like 23 years ago, you and I met. But what we're talking about today, compared to what we were talking about 23 years ago, I mean, it's night and day.
It changes
And
by month.
by day. And this is a great transition, Franz, to you, because research, right? Yes, the show is about what kind of really got affected during the time of COVID. Research was a really big one.
Absolutely.
And you were talking also that the lack of research that couldn't happen during COVID, there were patients that were under research studies that had to go away for a while. And just in general, the clinics and the research labs had to shut down for a while. Talk about your wish of research. We talked a little bit about this earlier, and I was really excited about it because there was a lot more going on earlier, and now we got to get back to that place. But you're the research guy.
For sure. So, again, one of the things that came out of the initial stages of the pandemic, kind of like a innovation, was decentralizing clinical trials. To run clinical trials requires a pretty robust infrastructure. And oftentimes the way trials are written, the PI, it states, patients will come in this day, this. And when you think about certain communities, you're asking them to come in a month's time, 4 or 5 times. And then the pandemic, which shuts all of that down, people really had to think critically about changing the way we approach how we do clinical research. And so that decentralizing came in the form of telemedicine. It's so interesting because these were things that we just never thought to do before. Clinical trials and the way in which we ran them, it's a tried and true method. They come in for the trial, they do this, or they're taking an oral medication. Maybe it's patient-reported outcomes, letting us know how they're feeling. But to come to a point where we said, let's add an element to this that's going to enable us to still care for that patient, still run our clinical trial. Again, these are a switch that we can't unflip.
Right. And that's what you said earlier. It's like now that you said we showed them our hand, right? And so you're looking at now how different things have gone. And in the positive, I know we're talking about, there's catch up, but in the positive of all this, you see this happening globally. I mean, there are certain things that we've done here in America, Europe, et cetera, but in general, pandemic's global. Do you see this kind of changing globally, and has it already started to change?
I do. I think there's a real big focus on population health, public health, that's coming into healthcare, coming into the hospital in a way that I certainly had never seen, I think, in my career. It's not just this episodic, someone has come in for this symptom, we've taken care of them, let's see what happens the next time they come in. And so you hear a lot about the social determinants of health. You hear a lot about, how do we care for an entire population so that they don't get cancer, so that we're not caring for them with regard to their cancer, and screening, again, right? Prevention, all of these things, education are huge factors. And we're thinking about different ways to approach how we do that now at a really, really large scale.
Exactly. And we're in El Paso, but we're also Juarez, we're also Las Cruces.
Right.
Our region is underserved medically and has been forever. And when I look at this, I get excited too that we're starting to bring in more and more. And we were talking about maybe a cancer center in El Paso's future, and that would be fantastic as well. Dr. Sanchez, were there any patients, and we didn't talk about this earlier, so I'm just springing this on you. Were there any patients that were in clinical trials that you were aware of when COVID hit? And if not, we'll just move on from there. And if so, what was the effect there? I mean, was the research just automatically stopped? Is it something, and again, cancer doesn't wait, right? It's not like you can do research, just, you know what, we're just gonna wait for 2 years and then we'll restart that research again. But maybe talk about a specification with that.
Yeah, so we had, I mean, in El Paso Cancer Treatment Center or Texas Oncology, we do have active clinical trials going on right now. I mean, and during the pandemic, so like he was saying, we had to rethink. I mean, how do we make sure that our patients are being monitored? Right. How to make sure that our patients are receiving the medications that they're supposed to be taking. And also, I mean, every protocol had to be rewritten in terms of COVID protocols. What happens if a patient gets COVID? We had to notify it immediately because it was now a severe adverse reaction because they actually were sick with COVID. We had patients that we had clinical trials open for, but patients could never be enrolled because they were not being screened or diagnosed or things like that. So we had to explain that when I was having my principal investigator meetings with the whoever was doing the research trial, they would be like, so what are the barriers to enrollment and I said, patients are not there.
Yeah.
The patient and especially it was very obvious in the pancreatic cancer arena that there was a first line pancreatic cancer trial that I felt it was fantastic, but there were no pancreatic cancer patients to be screened or to be enrolled. So we just had to, telemedicine was a great success for us in Texas Oncology because we had a platform already and we just deployed it across the board.
Right.
And we were able to keep our patients, keep track of our patients, keep track of their progress, make sure that, that they were able to get whatever studies they needed and also make sure that the drug, that they were on was available to them.
Exactly. And that's a whole nother thing, the whole supply chain, right? When you're looking at, you know what? Since you did it, speak about that because you're kind of, again, you're the miracle maker, right? And the guy that's got
he is my miracle maker. I have a lot of
buttering
hope.
you up. I need, you know what I need? I need this piece of equipment. I need these medications. I need you to get this for me.
I want oncology nurses.
Yes, nurses. Easy to say, I know. But let's talk about that idea about supply chain. And I know that's like a crazy buzzword right now, but we're looking at equipment. We are looking at medications. And in general, how has that affected what you do all day, every day?
And I want to even add workforce to that
because
that has become
that is
critical.
Huge.
Critical.
Right.
We saw a mass exodus, I think, of folks leaving healthcare or changing. Right. We call it the Great Resignation. I think it was this great reevaluation. People said, "What do I really want to do?" Because time is fleeting, life is fleeting.
Right.
And so there's a big shift in the workforce. And Dr. Sanchez mentioned oncology nurses. And across the entire El Paso community, we lost a lot of oncology nurses, a lot of nurses altogether. And how do we bring back that workforce that's critical to the entire enterprise, to caring for all of these patients? And that's something that the pandemic, I think, precipitated that we're still trying to figure out how to change and not making changes that are short-lived, but really creating, sustainable changes. How do we create a pipeline to get nurses to El Paso, or folks who are already here in El Paso, develop that? And that's something at the Hospitals of Providence that we're thinking through and working, and we've had conversations about it, building an oncology nurse pipeline to enable for not only for the patients we're caring for now, but the patients that we'll care for in the future. It's really about sustainability.
And there became a new phenomenon, which is the traveling nurses. Right. There was when COVID hit very hard in certain areas of the country, they needed more personnel. And so their career is a traveling nurse. Just in different meetings that I've sat with in the different medical areas, is that something that we've really experienced in El Paso as well?
Certainly. Not only have we needed traveling nurses, right, in the height of the pandemic here, the community was hit really, really hard. I was in Boston at the time, but I saw El Paso all over the news. But also now, to your point of that shift of our own workforce going the traveling nurse route, so now we've lost those individuals. So we absolutely were impacted. And I think now the thought is, how do we get the nurses we need now for the community now, and again, build for the future? Because, I've seen the cancer incidence rates. It's still happening. Lung being one of them. Hematologic cancers, the blood cancers, being another that we expect certainly to continue growing in the coming years. So we'll need a workforce to be able to meet that demand.
Well, that's something to talk about with high schoolers that don't know what career they want. They can go into nursing and always have a job, just like with education. Dr. Sanchez, you said a word earlier, and you saw me get excited because this is target therapy when it comes to cancer treatment.
Yes.
Is such a beautiful thing. I know it's not new, but it still fascinates me. And so to even broadly describe what targeted therapy is, how would you describe that? Because I know there are certain cancers that benefit more from targeted therapies than others.
Yes. So, I pretty much say, okay, depending on that biopsy, depending on the cancer, we do a battery of tests. Right. And what we do is looking for that particular target. So I call it actionable target, meaning that there's that place in there in that tumor that I can actually go after with a particular medication that has been designed to disable that target. And then
That's just cool,
I know,
right?
it's like army.
It is.
It's like the army. I'm going after it and I'm going to just kill you. But that's actually, and almost in every cancer, like breast has a lot of targets right now. And then, the lung has so many, like there's cancers that if we actually find a particular target, we actually do better with that medication that targets that mutation than with chemotherapy.
Right. See, so that is, chemotherapy was in the old days, I see old days, 25 plus years ago, it was usually there's a surgery, and then there's radiation, and then there's chemotherapy. And it almost was that you just followed that rule with most cancers.
Yeah. So these days we have more sophistication. We have to do all this testing. And then this testing is going to help us pretty much determine what we do for that particular cancer. And then if we can, and we're starting to be more like treat less, instead of actually trying to hit everybody who has cancer get chemotherapy. That's not the answer anymore.
Right.
We actually have to divide it in risk, and pretty much, and then other cancers are targets. And if those targets are present, we hit the jackpot.
And when you said that jackpot, 'cause I remember the first time we started talking about this, I don't even know how many years ago it was. But even the doctors that were on the air, they were like little kids jumping in their chair. It's like, oh, and we could do this now, and this is about to happen, and this hasn't passed FDA yet, but and it was beautiful. We're kind of at that mark in the show where I want to stop my questions to you and see if there's something that we have not yet talked about that either one of you want to get across before, because it's almost an hour and it happens super fast. So I'll talk to Dr. Sanchez first because she's the veteran, you're the newbie. It gives you some time to think. But this is a time really to think, you know what, we're going to be on an hour-long show tonight. We're on PBS, we're doing podcasts, we're doing all this stuff. What is it that we want to get across to our audience, to people in El Paso, but also globally too? This is all over the internet. So, Dr. Sanchez.
I just want to remind El Paso that unfortunately the pandemic is not over. I mean, I more than anybody want it to be over, but unfortunately for my patients, it's not over. They are immunosuppressed. They are very high risk of becoming ill and dying from this virus. So just, have compassion. Have compassion for others.
Keep going. There's a lot more in here, though. So
I'll cry.
The pandemic is not over, and I would love for you specifically, as the oncologist, hematologist, when we're talking about screenings, it's not over, but there's still, if you know that every year. Your daughter's turning 5 in September. So and for me, I try to get all my tests at least scheduled during my birthday month. My birthday's in February. So I think, okay, if I need to get my colonoscopy, I always do my mammogram, I do everything I need to do. That's what I'd love for you to be the cheerleader for.
So
yes,
we just know that as healthcare providers, we've been through this. We have made it on the other side, but at the same time, we are safe. We are safe for you to go to. We are safe for you to get your tests. We are probably the only people in the city still wearing masks because the CDC says healthcare entities continue to wear masks. So we are safe for you to seek care. So do not put it off. It's not gonna, if you have something that can be caught early, then you know what, this is the time.
it is.
So I don't want anybody to have any excuse not to go get their mammograms or their colonoscopies or to go see their doctor and get checked for their heart, their EKGs, their cholesterol. Heart disease is still out there, even though we're talking about cancer. Heart disease is preventable. It is something that we can do. Do your exercise, stay healthy, but just seek the medical care that you need because we are safe.
Right.
As medical community, we have been safe. I mean, we made it through a major,
right.
in at the end of 2020.
Right.
And we all pulled together and we made it.
And as Fran said, with a lot more that's going on, and I always try to have the audience see all three of us, whoever's sitting here, you have a family, I have a family, you have a family. And I'll say today, my son had his tonsils taken out today. That's a big deal. That's his first surgery. He's 19 years old. We waited. And part of us was like, well, he's the guy that had strep throat forever. We can wait for COVID to go away. And we were also in this mindset. So just me as a human being, as a mommy, I was in the same boat, like, oh, can we just wait? And it's the safest place to be. You walk in immediately. We were at one of the surgical day centers, and everyone was masked up. Everyone was separated. The way that we were able to go in and out, only one of us was allowed to be with him. It was so beautifully orchestrated that I was embarrassed and a little bit ashamed that we didn't do this earlier. He's needed to have his tonsils out for a while, and we kind of stayed up on it. So,
I had surgery on my foot at the Hospitals of Providence in April, and all of my patients know this because I just barely started to walk. So
see, this is the human part of us, right?
I that's the way it is. It's safe.
Yes,
it's safe.
It absolutely is safe. Franz, how about you? What would you like to get across this evening?
I think one of the things that's really important, especially when I think about El Paso as a community, and we've touched upon it, the health inequities, cancer disparities, where 80% of the population knowing the types of cancers that the population tends to have, the predisposition, it's so important to get screened, and I think it's so important to talk about it as well, right? Talk with your family, talk with your clinicians, talk with your friends, convince them to get their screenings appropriately as well, because it truly is something that can be preventable, certain cancers, and certainly the place to have it done are at our hospitals where we've always had the COVID protocols since the pandemic began, right? We've not become lax, right? We've been doing this, and we certainly want to see people get screened and hopefully get them treated for the cancers that they may have.
I want to give a high five. You said since the beginning of the pandemic, and this is really something that you being new to El Paso, I think that you probably already felt this. There is a community here. And yes, hospitals and medical systems, technically, they compete with one another. But when COVID hit, when it was time to test and screen, and then really when it was time to vaccinate people, again, the impressiveness to me, we were talking earlier that 83%, you gave me this quote, and I love it, 83% of El Pasoans are considered fully vaccinated. Yes. And did you say that at least that we're at 99% that has at least one vaccine?
One vaccine.
Did I understand that
Yes.
right? Okay, so that could not have happened with all of our entities getting together and doing the vaccines. And Franz, I'd like to ask you, we were talking earlier, and I keep saying that because we have all these conversations before we get here, which is great because that's where the gold happens, right? When we're looking at vaccines, for those people that have their 3, that's boosted, that's the 83%. Now you've got the 4th one, not everyone's got that one yet. But there was a time we were just going through lines at the Civic Center, going through lines at the Coliseum. So now where are people able to get their vaccines? And it's just nice, yes, this is a show about COVID and cancer, but where are people able to get their vaccines now?
Certainly at their primary care physicians and places like the CVS's and the Walgreens. This is not an advertisement, but just to understand that at your local pharmacy, right, that are still carrying these, they're still carrying the boosters. And again, this is that breaking down the walls of accessibility and enabling people to be able to get care where they need it, close to home, where they feel comfortable.
And I know this is all over the news, but sometimes let's just pretend somebody has not heard the fact that this is all free. There was somebody that had talked to me and said, well, you said on the air that it's free, but they were asking me for my insurance card. Well, why were they doing that? Are they billing me? At the end of the day, what they're trying to do is track who's got the vaccines, who has which vaccine, et cetera. So it's actually good that is the case. Dr. Sanchez, do you see an ongoing COVID vaccine from here on out, just like we've got an ongoing flu vaccine? And I know that you're an oncologist. I know that this is not your specialty, but just to the best of your ability, and Franz, you too, what do you see futuristically regarding COVID not going away and the world adapting to these different variants with different vaccines through the years, just like the flu? Who would like to take that question on? Throw it out.
I believe so.
Okay.
I mean, we are, there's multiple variants that are coming on. I mean, we were talking about that variant BA5, and, I know that Moderna has developed an Omicron-based vaccine that is coming down in the fall. But I do believe so. While we keep producing variants, I think we're going to have to modify pretty much vaccination.
Right. So if you don't mind, let me hit on that again.
But I am not sure.
Okay, I respect it. I respect it. Don't hold us accountable. This is it's an information-seeking program. So Moderna is looking at specifically an Omicron type of
Omicron-based
vaccine.
Yes.
Okay. You started in there and I stopped you. My apologies. So number one, I didn't know that. I'm going to do some research on that soon. So are we looking at that being, and again, you don't know, but most likely the 5th shot? Because when we double boosted, because we've got, and this may be another question, are all the 4 shots, if we've gotten 4 shots, are they all the same? Meaning, if you got Pfizer all along, are they all?
They're all the same.
So that's
based
something
on
that's
the
big.
initial
Okay.
COVID.
Okay, so and the reason too, because people are like, well, is that a different vaccine? Well, it's a boost. Does it mean it's a different vaccine than the first? At the end of the day, again, it's all the same vaccine. Moderna's looking at something that's specifically for Omicron, which is exciting.
Yeah.
That's good. Franz.
And to that point, it's because where you're looking at the BA.5 variant, it's immune evasive, so it kind of gets around the immunity that you may already have, and so and exactly what Dr. Sanchez stated with regard to the more variants we have, the more vaccines essentially we'll need. And our hope, right, is having enough of the population vaccinated, right? The buzzword herd immunity, vaccinated to suppress kind of the ability for variants to manifest, so we can get to a place where it's a lot more manageable with a regular vaccine program, a la the flu, getting it every year, getting the flu shot every year. So my hope is that, and I think the pace of medicine, the same kind of ingenuity and passion we see in the immunotherapy space and the target therapy space, it was that context of cancer research that enabled us to develop the COVID vaccine in the way that we did. So we were foundational for this, and I think similarly, the cancer care community will continue to be a huge part of how we think about COVID-19 and folks being immune compromised, because we've been dealing with that
for a really, really long time.
Entirety of our careers.
Yeah, and this is something too. COVID-19 is called COVID-19 because it came about in 2019. There were 18 COVIDs before COVID-19. Nowhere near what we're seeing now, but that is when people are talking about, I'm scared of the vaccine, it's still brand new. There's a ton of research that was gone before COVID-19, and it was just adapted for COVID-19, and it's had really, really great results on that. So, Dr. Sanchez, we've got like a minute. Is there anything that you want to say to the audience about getting their vaccine if they're still scared? I know we're good numbers here, but some people are still a little I
mean, I went first of the line to get my vaccination when it first became available to healthcare workers. My family actually drove all the way to Midland to get their vaccination. Everybody is vaccinated and boosted in my family. If I didn't feel it was safe, I would not give it to my children. So that's my biggest argument. And I just want everybody to be safe.
And that's, again, us just being human beings. We're being mommies, we're being daddies, we're being grandpas, and I'm not yet a grandpa or a grandma, but it's coming. But I wanted to say thank you so much. Franz, you've been welcome to El Paso. Again, you have probably not tried every Mexican food restaurant yet, but man, you got to get that on the list.
Is that even possible?
Maybe not, because they keep popping up. Dr. Sanchez, thank you. It's always great to have you here. Again, we've been doing this for more than 20 some odd years. And to the Hospitals of Providence for underwriting this program this evening. If you did not catch all of this, you can catch it again on pbselpaso.org. You can also get it on the El Paso County Medical Society website. That's El Paso County, just the acronym of El Paso County Medical Society.com. And then also YouTube. Anytime you want to look for past shows, just go to youtube.com. and type in there the El Paso Physician, and you will find just all the different episodes that we've had, as well with PBS and with the El Paso County Medical Society. I'm Catherine Berg, and you've been watching the El Paso Physician.